So we're moving through Unit 2. We're on Chapter 13. This is respiratory disorders. This is a long one, guys, so you got to hang in there. Hang in there with me. It's a pretty long one. So, all right. So, Chapter 13. So, our respiratory system in general, what's the purpose? Well, most of you know this: transport oxygen to the tissues, from air to blood to tissues and cells for cellular metabolism. We need oxygen as a critical component for our cells to perform their normal metabolism, for protein synthesis, for a lot of stuff. The other thing is remove waste products, and the main waste that is going to deal with our lungs is carbon dioxide, which is a waste product from our cellular metabolism. And basically, you can break down the whole respiratory system into two structures: upper respiratory tract and a lower respiratory tract. This slide's noting that the upper respiratory tract, so it would include your mouth, nose, larynx, even the pharynx, technically. All those areas have normal flora. They have fungi or present bacteria that hang out there, and they can actually kind of help us keep other pathogens out. Lower respiratory tract with the lungs and the bronchioles and the villi is sterile. Typically, shouldn't have any forms of bacteria or anything in there. Upper respiratory tract, you can kind of summarize that as three parts, really, in the sense. Nasal cavity, that's job is to warm and moisten the air, and this is an A&P review. Again, foreign things, dust particles, bacteria, viruses, hopefully get trapped in mucus secretions and keep them from getting to the lungs. Nasopharynx is the back of the nose that meets with the throat. Your pharynx is basically the back of your throat, and they technically subdivide the pharynx into three categories: nasopharynx, oropharynx, and laryngeal pharynx. Laryngeal pharynx, basically meaning the back of your nose, the back of your mouth, throat, and then where it meets with the larynx, where we house our vocal cords, and then we go into the trachea. But if you're looking at the upper respiratory system, you're thinking nasal cavity, back of my throat is the pharynx, and then larynx, where your voice box is. Also, they include your tonsils are in there. You have palatine and laryngeal tonsils housed kind of around your opening of the oral pharynx towards the back of the throat, and those are part of your lymphatic system, house white blood cells, prevent infection, that sort of thing. Here's the anatomy of kind of all of it. Again, you kind of subdivide nasal cavity, larynx, back of your throat, and pharynx, where your voice box is upper. And then starting from the long muscular tube that runs all the way of the anterior section of our throat to the lungs, that's the trachea. And then you get into the branches, the bronchioles that branch off into each of the lungs. And then the tiniest part, the microscopic level at the very end of all this kind of upside down tree, basically, here of the upside down tree is the bronchioles, you have the alveoli. Alveoli are these sacs that gas exchange happens in. So that's the anatomy summary. Again, upper respiratory tract. Sorry about this slide, it's a little bit weird, but yeah, nasal cavity, pharynx, larynx, and then we work into the lower respiratory tract, which mainly talking about the lungs here. The trachea is the long tube. It branches into primary bronchi and then secondary bronchi, and then bronchioles, terminal, right? Just gets smaller and smaller and smaller. Look at the lungs from the trachea all the way around as basically an upside down tree of these openings that are hollow called bronchioles that get smaller and smaller till they meet with alveoli, these sacs that are filled with air. And this is where the gas exchange happens. The alveoli are very simple squamous cells, so very simple square single cell layer, very thin, kind of like a blood vessel. And they also house a chemical called surfactant. If you remember this from A&P, surfactant is a chemical that kind of repels water, basically, and that keeps the surface tension. So it basically just maintains inflation. So the alveolar sac stays inflated and it doesn't collapse on itself. And again, this is where the point of gas exchange happens, the alveoli. So ventilation, all ventilation means is the process of us inspiring and exhaling. So inspiration is breathing in, expiration is breathing out. You can also say inhale or exhale. IN means in, right? EX means like exit. So you can always know that. Um, how we breathe depends on the pressure gradient. It's technically called Boyle's law, but basically air is always going to move from high pressure areas to low pressure areas. And that has a lot to do with the muscles around our chest, our diaphragm. And that's what kind of makes us breathe, basically. So atmospheric pressure is higher than the pressure in this small microscopic alveoli, and that forces air in through inspiration. Uh, and then expiration, as our lungs fill up with air and do the gas exchange, that pressure change actually changes. We're now all of a sudden in the alveoli, in the lungs, on our at the very end of inhale. Breathe in, lungs are full of air. Now the pressure's higher, and the relaxing of our diaphragm and the other chest muscles, and that pressure shift forces air back out. So, from that discussion, think about breathing is based on pressure, and also think of breathing as based on pressure, and think of it as inspiration. Breathing in is a more active process, requires muscle contraction from the diaphragm and other muscles, and it's a more active energy based process, where exhalation or breathing out, expiration, should be a more passive process. The muscles relax and air moves out of the lungs based on the pressure gradient. So it's a passive process. So you want to take home point from that is keep in mind that breathing in is an active energy cost process, where breathing out should be a passive low energy cost process. So pulmonary volumes, there's a bunch of different volumes. There's highlighted a couple here on this slide, but you have tidal volume, which is the amount of air exchanged with normal kind of relaxed, quiet inhale and exhale. Residual volume is a volume of air. And again, volume is a word we like to tend to think of measuring liquid like milliliters, liters, but volume is a measurement of space in a container, basically. So you can use it for air as well. How much air takes up this much space? So residual volume of air is the air that remains in the lungs in between the inhale and exhale. There's always going to be a residual volume, and there has to be, right? Because as we exhale, we can't breathe out every bit of air from our lungs. One, the lung pressure would drop so much it probably cause a collapse. Two, gas exchange still needs to happen. What's going to happen in the couple seconds there between inhale and exhale? If there's no air in your lungs, you wouldn't have gas exchange happening. Therefore, you'd have this big drop in oxygenation and then you'd pass out. So this is a natural process that we would always have a residual volume amount of air that's still in our lungs just after we exhale. So no matter how hard you try, you can't get rid of all the air out of your lungs by design, right? So we can keep gas exchange happening. So keep that in mind. Vital capacity means the maximum amount of air that can be moved in and out of the lungs with a single like breath cycle, forced inhale and exhale. And so your vital capacity would change depending on, like, if you were suffering from pneumonia or the flu right now, and had chest congestion, something like that, your vital capacity might be diminished based on that. Or if you're, again, a COPD patient that suffers from a chronic lung disease, that kind of thing. These are all of them here to give you an idea. I wouldn't say you need to know all of them. That slide gave you the kind of need to know the more important, like, numbers and names for the volume measurements in pulmonary and the lungs. And being pulmonary, you need to know from A&P, pulm just means lungs. So pulmonary is talking about the lungs. Someone that studies the lungs, there's a lung doctor. That's a pulmonologist. But these are some of the other ones: tidal volume, residual. You have expiratory reserve. There's vital capacity. Total lung capacity is really high, but we never really utilize that. So what controls ventilation? Primary control for breathing is the control centers in our medulla oblongata. That is a section at the most inferior portion of our brainstem, right where it connects to the spinal cord. That is our control medulla. The medulla oblongata is the control center for also our cardiovascular control, respiratory center. So think of it as a vital organ center. If you don't remember that from neuro and A&P, the medulla is like our vital center, basically. Blood pressure, heart rate control, breathing control, that sort of stuff. And so we have chemoreceptors that detect changes in O2, CO2. Mainly they're detecting changes in CO2, hydrogen, and blood as well as CSF, and then they dictate, our breathing pattern based on that. They're much more responsive to CO2 levels actually than oxygen, and we'll talk about that more with the chronic lung diseases in a minute. So this is just a chart that's in your book that talks about respiratory control and how we go about doing that. But basically, the normal cycle is, if we increase our CO2 a little bit, this is going to tell the medulla to stimulate breathing in. We breathe in and then we breathe out CO2 that decreases our CO2. That stimulates the chemoreceptor to slow down respirations, and then it just kind of repeats from that. And it's more based on CO2 than it is O2 necessarily. So if you're going to keep kind of anything in mind from a discussion about how we regulate this, keep in mind the medulla is the respiratory vital center, and that it's more what's the word? More sensitive to CO2 changes than it actually is O2 changes. And that's going to matter later when we talk about some other stuff. Kind of on that too, the two things that do control it, we do, read changes in oxygen levels, and our medulla will respond to that. Hypoxemia, hypoxia is just saying lack of oxygen system wide. Hypoxemia says lack of oxygen in the blood because it ends in that emia. So hypoxia, hypoxic is saying someone has suffering. Saying hypoxic would be saying someone is suffering from being hypoxia. But hypoxemia is saying we have a marked. The only way you can really say someone has hypoxemia is really if you had a blood test, ABG, that said their partial pressure of O2 was low, and then you'd say they have hypoxemia. Otherwise, you would just call them hypoxic or suffering from hypoxia if that's what they were symptom of. Hypercapnia, again, there's a hyper, so as a prefix, right, that means high. Hypercapnia is too much CO2. So you can kind of remember, if you're trying to remember that term, you can see the hyper is high, and then you can see the cap as high C capnia O2. If that helps you kind of remember what hypercapnia means. High C cap with a C CO2. That's someone that has high CO2 level. And this is kind of showing the hypoxic drive. Again, you got chronic CO2 elevation. This is an interesting discussion. So this is a I wouldn't say it's a hardcore need to know, but I'm going to probably go ahead and say that this is a need to know. So think about that again. Our body is more responsive to CO2 typically. Well, let's say that I'm a person that suffers from a lung disease chronically. So I chronically have slightly elevated CO2 levels compared to normal. The normal for an ABG was 35 to 45. But let's just say that I normally sit at like 52 millimeters of mercury, 52 CO2, a lot because I have chronic lung disease. Well, eventually the responsiveness to CO2 becomes a little bit desensitized by the medulla. And then as CO2 rises, we don't respond by trying to blow it off as much. Then the O2, I suffer from hypoxia. If the O2 is dropping, that'll stimulate the muscles to breathe. It does remove CO2 and hopefully increase the O2. So that's another way that we kind of regulate. But this is typically more with people that are suffering from chronic lung diseases where their CO2 levels aren't rise. And this is where we'll talk about, this is where I'm talking about the need to know. With people that have chronic lung diseases like emphysema, chronic bronchitis, sometimes because of these elevated CO2 levels, it's bad to give them high, like 100% oxygen, and not what's called a non-rebreather mask, where it's giving this max amount of O2 we can give somebody, because their body is basically saying, I'm getting enough O2. I'm getting enough. So I don't need to increase my respirations. I don't need to market that. And so instead of the respirations will slow too dramatically, and they could even stop breathing. So you can give them high O2 if you need to get their O2 up, but you can't do it for long periods of time with someone that has chronic high CO2 levels, because it's almost like masking it. Their body thinks you start pumping O2 and their body thinks, well, I've got enough O2, so I can just slow my breathing down. And then their body doesn't understand that they might slow it down too much because they don't have that CO2 to help kind of balance it out. Their body's not, it's not desensitized to these levels because they stay high. So I can explain that more in person, but that's a keep in mind. I'd say it's just a need to know forever because it's going to come up again the more in adult health and more things you talk about. Every time you talk about the respiratory system, this subject matter about how people regulate their breathing is going to come up. So think of it this way as a summary, right? You think of it that normally everyday people, CO2 is a stronger marker for us needing to breathe more because it will blow it off. But with people that have diseases that cause chronic levels of higher CO2, their marker is O2. Now, their decrease in O2, oxygen, is going to be the marker that makes the medulla respond. And so someone like that, if I give them a bunch of high levels of oxygen to try to help them breathe, I probably will. But as their response diminishes because their body thinks, well, I've got enough oxygen, why do I need to keep breathing so much? It will slowly, they could stop breathing. So you have to be very particular and time oriented, time sensitive, and careful when someone has chronic lung diseases and giving them high levels of O2. And that's the non-rebreathers, the 100% flow, like high levels. They can have a nasal cannula that's different. So something to keep in mind there. So moving forward, again, control of ventilation, hypocapnia, low levels of carbon dioxide. You really only see this in kind of one case of the panic attack hyperventilation scenario where you're getting respiratory alkalosis. And again, our breathing would kind of speed up to blow more CO2 off. Very shallow, fast breathing. That's that breathe them, put the brown paper bag on them kind of so they can breathe into that kind of thing that I've talked about before with respiratory alkalosis. So gas exchange, what's happening here? So the flow of gases, this is basically when you say gas exchange, you're talking about the movement of O2 and CO2, movement of oxygen and carbon dioxide through the alveolar wall, that small, thin alveolar wall, because all the alveoli have their own dedicated pulmonary circulation and their own, we talked about that in chapter 10 some, the blood flow of the vascular system. So we have our own separate pulmonary system that comes from the right side of the heart with poor oxygen, poor blood coming back from all the tissues, goes to the lungs, and that circulation wraps itself out in small capillaries around each alveoli. And we have millions of alveoli in our lungs. And then that's where the gas exchange happens. So it depends on the partial pressures. It depends on the pressure of those O2 and CO2 molecules. So it's on the pressure gradient, just like diffusion, anything, typically things lower pressure of something is going to move to pairs of, or higher pressure is going to move from areas to lower pressure. It's going to try to equal out pressures effectively based on the reality that's in the alveoli. And so that's how they operate and they do gas exchange. So that's why breathing can get weird if I have too low partial pressure of O2 and too high partial pressure of CO2. Those can mess with breathing patterns, that sort of stuff. And this is just a diagram to show you that the pulmonary capillaries around if you were to talk about a single alveoli, you would say alveolus. Alveoli is technically plural, but I might say it as a singular sometimes. But one single of the millions of alveoli in your lungs, you would call an alveolus. Does that really matter? No, but just that's why it says that, so you're not confused. Yeah, and so basically the pulmonary circulation comes from that, again, from that right side of the heart as a artery because it's going away from the heart, but it's oxygen poor, makes a capillary around each alveoli, does the gas exchange, and then the blood returns to the left side of the heart. So boom, it can get pumped to the rest of the body and bring that CO2 or CO2, bring the oxygen. And so this is just a chart to show you that process of pressure movement, normal diffusion of gases. These numbers these aren't like I have to know these numbers. Hopefully it's just, this is a chart that's nice and helpful to kind of give you an idea of, I get a lot of O2 and a little bit of CO2 when I breathe in, and that pressure difference allows me to do the exchange. and then I breathe out a higher pressure of CO2 compared to O2, but I'm going to breathe out some O2. So this just is what's happening in the alveoli side. So again, what's going to factors that are going to affect diffusion of gases? I would say that this slide is definitely need to know because you want to think about it. So pressure gradient. So again, that's what I mentioned before. If that CO2 level changes in the body, if the O2 level changes in the body, this can affect the gas exchange. Thickness of the respiratory membrane. If there's fluid or mucus production is excessive, as in the case of infection like pneumonia or other diseases, the fluid and other stuff is going to build up in the alveoli, and that basically they're like little balloon sacs. And if I fill a balloon up with water, right, it kind of deforms it. And so their ability to expand and contract like a balloon or a pocket is going to be diminished. And then therefore gas exchange will be diminished. Surface area available for alveoli. If alveoli are like physically destroyed or size is reduced based on certain lung diseases, that's going to affect gas exchange. And then ventilation perfusion ratio is basically the ratio of like airflow to blood flow. We need a good one. So you can also think this is why the ventilation perfusion ratio is a thing. This is why if someone has anemia, right? Who carries all this gases? The red blood cells. They carry the O2 and they carry the CO2. So if I have less red blood cells, anemia, right, my ability for this gas exchange is going to be diminished. And that's why I mentioned in chapter 10, like you think anemia, you think lower ability, lower oxygen carrying capacity, lower capacity for gas exchange. And so someone with really severe anemia will not only have that pallor or tachycardia, but they're probably going to have, maybe not, they're probably going to have tachycardia, tachypnea. They're going to have increased breathing rate because their body's trying to breathe and it's not getting effective gas exchange. So they'll have shortness of breath. So kind of keep that in mind. Transport of oxygen and carbon dioxide. Again, these are the two chemicals that matter the most for the lungs. This is a graph that illustrates the factors affecting the exchange between O2 and oxygen and hemoglobin and CO2. This is not a need to know. This is kind of gets into the weeds. If you're a numbers person and you like seeing graphs that kind of explain things in the numbers, this is nice, but this is not something you have to know. If you look at this and go, that looks confusing and that's not helpful, then ignore it. Okay. So what are some diagnostic tests surrounding this? Well, we have spirometry. Basically, you probably heard of something called the incentive spirometer that we use in patients in the hospitalized or post-op patients to make them take deep breaths. But spirometry in general is a term that talks about breathing devices, and we can do what's called PFTs, pulmonary function tests. So if you're kind of highlighting tops from this, you could say PFTs. There's one. Pulmonary function test means we have someone breathe into a spirometry machine, and it gives us some readings about things like that tidal volume and expiratory volume, inhaling volume, those kind of things, right? ABGs are always good because that's going to show us acid base imbalances. That's going to show us this carbon dioxide and O2 levels. We could do a pulse ox, usually the shorthand for this. Oximetry, pulse oximetry is just a little probe that you put on someone's finger, and it bounces an infrared signal basically into their nail bed to look at hemoglobin versus oxygen concentration and give us a percentage. Typically 94 to 95% to 100% is considered good. Anything less than that's considered on the lower side. And then you can just see how well they tolerate exercise, because that's going to ramp up the metabolic need of the cells, therefore ramping up the need of oxygen and so to speak. But these are kind of your 1, 2, 3 most common. Probably the most common is I should number that correctly. 1, 2, 3 basically, but you don't have to know in order. I'm just saying we always check a pulse ox for vital signs for most patients, right? If we're having issues, we could check ABG, and if someone they're considering has some kind of lung disease, they'll do PFTs and see like what the volumes are, that sort of stuff. So think of PFTs as more about the volumes. Other things we can do is radiology. X-rays are great for diagnosing pneumonia and other conditions. Um, if there's really some investigation, really some deep investigation going on, they can do a bronchoscopy. A bronchoscopy is actually going in with a scope into the airway to trachea into the lungs to look around and see damage or see inflammation or see what's going on there. And then we can take swabs of sputum. So the word sputum you probably have heard before, but if you heard, just so you hear that word, I don't use it without defining it. Sputum is just any kind of phlegm that you get when you cough up. So I'm not talking about normally like maybe the drainage you'll have from your sinuses. You wouldn't necessarily call that sputum, but actually like if you have a respiratory infection where you can feel it in your chest, you've ever had pneumonia before, you'll have a cough that's coming deep from your chest. And that is the mucus and debris and maybe the infection coming from the chest. And when you spit that up, that's sputum. So sputum is secretions from the lungs, not necessarily your upper airway nasal cavity. But we can take that sputum sample and culture it and see what's growing in it, and then do sensitivity tests to see what antibiotics might be effective in treating whatever disease. So those are some of the tests. I'd say that most of those tests or need to know is kind of put it all together, right? So what does that hemoglobin dissociation curve represent? What is that representing that we were talking about? What is that trying? And think of what is any assessment of oxyhemoglobin just means how well is hemoglobin and oxygen combining? What does that tell us? This may not be my finest question, but they're not all winners. Okay. You can't be, they can't all be winners. All right. I'll give you a second to answer. Okay. If you said number one, I kind of gave that one to you. Basically, the affinity. How well is oxygen hemoglobin coming together? How well are they combining? If they're not, then we need to look into why. What test measures pulmonary function by assessing lung volumes and airflow? If you said spirometry, that's correct answer. So manifestations of respiratory disease, these are pretty obvious, but what would you see? Sneezing, coughing, runny nose, congestion, sputum, again, coughing up stuff deep from the lungs. Changes in breathing patterns, definitely more serious. Those would all be manifestations. Again, signs and symptoms you would see with lung conditions. Respiratory patterns. So there's some interesting ones in here. So let me highlight some need to knows. I think let's just highlight some of these need to know. So eupenia up there at the top, EU. So here eupenia at the top is basically saying normal, smooth breathing, what we always want. Okay, cool. Easy peasy. Eupenia. Think of it like euphoria is, I don't know. Well, euphoria doesn't really help. Euphoria is a kind of a feeling of high, basically, and joy, but this is normal. Eupenia, utopia. I don't know how you want to remember that, but it's perfect. Perfect breathing. Eupenia. What you're doing, hopefully, right now. Tachypnea and bradypnea is rapid for tachy. We know that with heart rate. Brady means slow heart rate. So bradypnea is just slow respiratory rate. Typically, bradypnea is just slower than normal, but it's a regular rhythm. Typically, tachypnea can be irregular or regular rhythm to it. Apnea, most of us have probably heard this, probably heard of sleep apnea. This is cessation. This is stopping breathing while you sleep. So apnea is just stopping breathing. That's another need to know. So we got eupenia, tachypnea, bradypnea, apnea. Cheyne-Stokes respiration. So Cheyne-Stokes is this periodic breathing. This is usually associated with like a breath with a apneic period, and then it's pretty regular and cyclical, but it typically increases. This is in line with some respiratory diseases and conditions, but it can vary. This is also commonly seen with some of our with acidosis. Sometimes it just kind of depends. Kussmaul's respirations. These are deep, regular sign respirations with an increased rate. And this is you see this as trying to blow, can't type, blow CO2 off. You'll see these more in line with acidosis, only because this is a compensating mechanism. Our body is actually making itself. This is very similar. Kussmaul respirations are very similar to hyperventilation because the goal is our body is trying to blow off CO2 or is trying to decrease CO2 levels. And so you see this with acidosis, Kussmaul respiration, as a compensation mechanism, basically. So I'd highlight those as kind of need to knows. So, general manifestations of respiratory disease, typically you're going to see changes in breath sounds. So, these are also need to know. There's a lot of this in here. Respiratory system is one of the kind of big three. In the nursing world, we label kind of everything as ABCs, right? Airway, breathing, circulation as prioritization for patients with issues. So, if the airway is not open, then it doesn't matter what the lungs are doing, then it doesn't matter about circulation. So they kind of go ABC as 1, 2, 3. I got to worry about, is the airway open? They don't have a hot dog lodged in their trachea, right? And then is their lungs working well? If that's not the case, then is circulation doing okay? So it's kind of looking at stuff like that. So this would be the B of breathing. This is a pretty big priority about. Generally, you could think of, if someone's brain doesn't work, their lungs don't work, or their heart doesn't work, one of those big three, then we're in trouble. And probably your number 4 on priority organ systems is probably the kidneys because of just how much they control. And then if you want to say priority system number 5, the top 5 body systems being messed up that's going to cause system-wide problems is probably the liver because it does so many different things for us. So you probably go in that order of like brain, heart, lung, well, probably brain. I said it backwards: brain, lungs, heart, and then kidneys, liver. But that's a rabbit trail. I'm just going on a rabbit trail there. That's not need to know, but it's like I like to talk to people about that. So breath sounds. What are some breath sounds? So there's something called rales, is the technical name for it, which rales is like subdivided basically into either fine or coarse crackles. So this is like snap, crackle, pop, like the sound that the Rice Krispies cereal makes. I know most people just eat Rice Krispie treats these days, but there is a Rice Krispies cereal still out there. It's not bad. But Rice Krispies cereal, when you pour milk in it, because they're the crispy, the Rice Krispies, I don't know what you actually call those things, are aerated. They have air pockets in them, and so they sound like little tiny pop crackle things going on. Almost like what was that candy? I don't know. They still make Pop Rocks. If you're like a '90s kid, like I was, and you probably heard of Pop Rocks, kind of that thing. But they don't always sound like that. I'm just giving you an idea of what people were talking about when talking about crackles. That's what you would think of. So they're crackling sounds. They can be kind of really fine and like a low, very low tone. They can be very coarse and kind of a loud, audible tone. And you shouldn't really hear these by your own ear. You're probably going to hear these only with a stethoscope. But you shouldn't hear anything. You should just hear a very light whooshing of air when you listen to someone's song. It should be very normal and very rhythmatic and just a light whooshing sound. When you hear crackles, that's usually talking about a bunch of secretions or mucus buildup, and that would be in chronic lung diseases and pneumonia, anything that's affecting the lungs. Rhonchi are a much deeper and harsher sound when there's a lot of mucus buildup. Rhonchi are similar to crackles, but very, very harsh, like loud to the ears. And then if there's no like sound at certain portions of the lungs, absent breath sounds, that's a concern because we think that part of some of the alveoli have physically lost their balloon effect and have collapsed, and that means part of the lung is not working. So that's a concern, obviously. Other general manifestations, typically dyspnea. These are still kind of in the need to know. These are all need to know. Dyspnea is a general term that is a term describing subjective feeling of discomfort when a person is unable to inhale, basically. So when someone has trouble breathing in, again, that is a effort muscular process, but when they have trouble breathing, they would describe it as, I'm having trouble breathing. that term is dyspnea. So think of difficulty breathing. If you hear dyspnea, not necessarily painful, it could be, but when I hear dyspnea, I just think of dyspnea with a D. I think just difficulty breathing, however that looks, or however that person describes that some subjective symptom is dyspnea. Difficulty breathing is how I think of dyspnea, because again, with a D. Severe dyspnea, yeah, severe dyspnea and like noticeable visual changes that you would say, like if you look at someone and you can objectively say they have dyspnea instead of them subjectively reporting it, then it's a serious issue. And then another one to highlight is called orthopenia. Orthopenia is basically dyspnea, so difficulty breathing that occurs when a person is lying down. You see this common with the chronic lung diseases or someone that suffers from pulmonary edema, fluid buildup in the lungs. They have trouble. They can't like lay flat and sleep. These people will sleep in like in a recliner or something that has their head very elevated or elevate their head a lot with pillows in bed. They can't sleep flat. That's known as orthopenia. Just more general, again, dyspnea. They could have pain around their pleura, which is the membrane around their lungs. So they could have chest pain that's like unilateral on one side or the other. That wouldn't really indicate maybe cardiac issues, but more related to their lungs and breathing. And then cyanosis is kind of always a general sign, because people with any respiratory disease are going to have potential for low oxygenation, which cyanosis is basically just means blue tint to like periphery, usually skin and like the fingers, nails being really pale or blue. Things like around the mucous membranes of the lips and the mouth, that sort of stuff is the blue tint. That's would be cyanosis. Other general manifestations that you'll see, maybe changes in ABGs if we did one. A friction rub is an interesting one. I wouldn't say it's necessarily a need, but it's more of a like a nice to know. But this is a kind of a soft, rough sound, if that makes sense. It's hard to tell. It's like very much you're gonna hear with I think only well, I think you can hear this with inspiration, expiration, but some sounds you're more predominantly going to hear with expiration versus inspiration, um, because it's a relaxed process. But basically, the pleura, the membrane, is either scarred or inflamed or has fluid on it, extra fluid than it's supposed to, and that can cause what they call a friction rub, and it'll make a friction kind of sound. Club digits, I would say out of this slide for like manifestations, this is probably the big need to know, because people bring this up with patients. And so you want to know what this is. They're talking about like clubbing of the nails and, not going to the club with the friends, right? Um, what they're basically talking about is chronic. This is only really seen in chronic conditions. So if you're a kid or, one of us that's a somewhat healthy adult in the 20s, 30s, 40s, 50s, you may not see this. If it's just a one time acute lung disease like pneumonia or a severe viral infection, you're not going to see clubbing of digits, clubbing of the nails. But with someone with chronic low levels of oxygen, for respiratory and even cardiovascular diseases like congestive heart failure, you can also see this in heart diseases. It's basically an enlargement of the end of the fingernails usually. And so what I mean by that is like, so if I'm looking at someone's finger from like the side on, this is bad drawing. I don't know why I can't draw like, but that's kind of their nail, finger and nail bed. Someone with clubbing is going to have like a obtuse round. That's really bad, but more like a rounded fingernail and like a short ill-formed fingernail that doesn't look healthy and a more rounded finger. That's where kind of the of the clubbing like digits kind of comes in. It looks like a club you'd hit someone with or something. That's where that name comes from. You can you'd have to see. I should have put a picture in here, and I can show one when we talk about it in class. But yeah, that's what clubbing is. Again, indication of chronic lung disease, chronic cardiovascular disease. So infectious diseases. Now we're kind of moving into that discussion. We've kind of gone through all the A&P, and then the signs and symptoms, manifestations of kind of chronic or acute lung disease. So what about infectious diseases? So we have diseases that affect the upper airway, especially, and the lower respiratory tract. So all your upper airway infections are typically, common cold, sinusitis, epiglottis, flu. That's influenza. Influenza is the general name for all the strains of flu, scarlet fever. So common cold is typically a virus. You're usually treating symptoms. You proper hygiene, hand washing, staying hydrated. It's spread through respiratory droplets. So I think I mentioned this in one of the classes, but respiratory droplets is droplet. It means that like whenever you're talking to someone, you're close enough distance, you're talking face to face with someone. When you talk, we always kind of spit a little bit. Those are respiratory droplets from our airway or upper airway nasal cavity, and they make it out of our mouth and hit someone in the face. And you would never, they're microscopic. You never feel them. I'm not saying someone's actually spitting on you, but they kind of are when you talk to someone and there's an exchange there in the air and through spit that can lead to, that's why close contact with other people is, leads to spread of the illness. So typically we want to treat with any common cold with a virus, you just got to treat the symptoms. A virus mutates so fast and your immune system can target, you have to just let it run its course and burn itself out, basically. Because there aren't a lot of antiviral medicines and they're very complicated to make. And the only ones we have are very specific on how their mechanism of action. They don't work for all viruses. So this can cause a secondary infection like a pneumonia. And this can be still viral, or it can actually turn into an opportunistic infection from the normal respiratory flora of the upper airway and turn into a pneumonia that's bacterial, which is easier to treat. Anything with a virus, you just always kind of keep in mind that viruses, because they're so mutable, they mutate so much, they can typically be pretty benign, but viruses can be hard to treat and get rid of because of their mutation. So other stuff like sinusitis. Sinusitis is just usually a bacterial infection of your sinuses. Sinuses are basically air pockets in some of your bone. There's some on top of your kind of eyebrows, upper nose, lacrimal bone, embedded in the cheeks, and they help with like air pressure management between the nose, inner ear, and your mouth. And they can develop infections with buildup of edema and mucus in those places. Uh, croup, because laryngotracheobronchitis is such a hard one to say. People call this condition croup. I'd say croup is a good need to know, but not necessarily right now. Croup will come up again when you do peds for sure. Croup is a common viral infection typically seen in children, especially that newborn to infant stage. This is para-influenza virus, and adenoviruses cause this. It's self-limited, meaning it usually runs its course, but the thing with croup that people always talk about is it does this like barking kind of cough that sounds terrible, especially in a little baby. It sounds awful. So that's what croup gets the name croup, because it sounds like a whoo sound, like the cough sounds like that. The croup is how the sound of the cough sounds. That doesn't really make any sense. Don't focus on croup. Focus on your common cold, other viral infections. We want to focus on the need to know being influenza here. Know that the flu is called influenza. There's where flu gets its name. It's in the name, influenza. And this is just a group of viruses. There's type A. Influenza A is the most prevalent, and there's also flu B and flu C, and a bunch of different mutations and different strains of the virus in these three categories. A bunch of them, thousands of strains. So it's usually going to have pretty acute sudden onset with a high fever, fatigue, body aches. You can get a viral pneumonia to embed itself because of the flu. Mild cases can be complicated with those opportunistic bacterial pneumonias. And most commonly, if it progresses to pneumonia, that's where people have the death statistics from. And those are people usually that have immunocompromised. They're immunocompromised for some reason. They have other chronic conditions that would cause it. Scarlet fever is an interesting one. It's an important note. This is actually caused by a bacteria, Streptococcus pyogenes. Streptococcus pyogenes is part of kind of the normal flora. This one's unique. We're highlighting it from the book because it causes this unique strawberry tongue as a manifestation. They're going to have fever, sore throat, and chills, malaise. They also can develop a fine rash around their neck, chest, neck area, groin, even. That's also a common manifestation of scarlet fever. But this is that red strawberry tongue. Typical strawberry tongue is pretty common. Basically, it's because that Streptococcus pyogenes, excuse me, releases an exotoxin that inflames the tongue in this very specific way. So scarlet fever is an interesting one. Think about the unique symptoms. Again, when you get yourself mixed up, if I said scarlet fever, right, versus influenza, how could you know the difference? Well, they all have very general common cold symptoms. How are they different? Well, scarlet fever has strawberry tongue and maybe sore throat. And you don't necessarily always see sore throat. You definitely don't usually see strawberry tongue with the flu because this specific bacteria causes the strawberry tongue thing. So, right, make differences. So, lower respiratory tract infections, bronchiolitis, pneumonia, one of the more common ones, severe acute respiratory syndrome, SARS, COVID is now in there, tuberculosis, also known as TB, histoplasmosis, anthrax. We're not going to talk too much about histo or anthrax. Slides are trying to cover the big guys. So pneumonia is always going to be a need to know because it's probably one of the most common lower respiratory tract infections that we deal with. So we classify the pneumonia based on what it causes. Again, commonly, this pneumonia is more commonly bacterial, but it definitely can be viral. And it just depends on the certain patient, that sort of stuff. One thing to note here is something called aspiration pneumonia. So if you've never heard of, a lot of people shorthand pneumonia like this, PNA. I don't think that's an approved abbreviation, but I'm going to use it right now for saving time. But aspiration pneumonia. So if you don't know that word aspiration, what the word aspiration was, I would say this is need to know. This is just need to know. So what the word aspiration means is that I have taken food or liquid, stuff that's supposed to go into my stomach and my GI tract, and it has somehow ended down my trachea into my lungs. Now, how this happens, we've all accidentally had a water or a drink go down the wrong pipe, right? And you start coughing, they have a coughing fit. That is technically aspiration. Even if it was like a small microscopic drop of fluid that ended up hitting your trachea because you were trying to talk and eat and drink at the same time, that is technically aspiration. And most of us do fine with that. But people that are especially the older, the geriatric population, because their immune system doesn't work as well, and among other things, if they are to aspirate like that, it could lead to infection because whatever particles from food or liquid that carry, sugar and other components and carbs and other things are a perfect breeding ground for bacteria or, pathogens, microorganisms. So aspiration pneumonia is a pneumonia cause. Typically it's nosocomial, related to this acute aspiration episode. This is also why they want people to be NPO, nothing by mouth, at least usually 8 to 12 hours at minimum before a surgical procedure, especially one that has full sedation. Because full sedation, you lose the ability of the gag reflex goes away. And they're going to have you on the table operating whatever. If your stomach is full of food, the possibility that you will suffer vomiting, emesis, and vomit, and the potential for that vomit to end up in your lungs is much higher during a surgical procedure, therefore leading to infection. So we try to avoid that by having people not eat or drink anything for that amount of time before surgery. That's why people have to be NPO before procedures. So it's a related to aspiration risk. There's something called silent aspiration that happens in older adults who lose some of their gag reflex and their ability for their epiglottis, the muscular flap of connective tissue and muscle that closes over your trachea when you're trying to swallow food. That gets a little bit ineffective, and it doesn't always get the close over the trachea. And then food or particles or whatever is going to go into the lungs, and then it causes aspiration. They don't necessarily know they have it. That condition where they have trouble swallowing like that is called dysphagia. So COVID-19, coronavirus, talk about it. Rapid attachment and damage to lung tissues. COVID-19 was a virus that specifically really did target lung tissue. The need to know from this is that a lot of times some of the deaths associated with this was that they found that it was causing something called cytokine or cytokine storm. Basically, cytokine or cytokine is another chemical mediator like histamine, where it causes local inflammation response and vasodilation. And so it would huge amounts of cytokine would get dumped in the blood system, causing kind of a local huge amount of inflammation in the lungs, even systemic effects, and that would cause alveoli collapse and that sort of stuff. And then that was always more risky with older adults or patients that were immunocompromised, their immune system not working that well, or again, people with comorbidities, diabetes, heart disease, obesity, that sort of stuff. So that's why COVID-19 had caused so many deaths, likely. It's related to that cytokine storm. So that's neat to know. Again, very strong inflammation. Symptoms for them, very similar to the cold: fever, chills, general fatigue. Temporary loss of smell and taste was kind of unique. So if you're trying to think of differences between like flu, scarlet fever, you can think of that temporary loss of taste and sense of smell is very unique to that coronavirus. Sore throat, nausea, vomiting, that sort of stuff. So if I were to ask you, sorry, which of the following best describes the pathophysiology of COVID-19? Have you said number 4? You're right. Think of that cytokine or cytokine storm and severe lung damage. So, still moving on with infections of the lungs. I told you guys, hang in there. This is a long one. Tuberculosis, TB. The cause of TB is a specific bacterium called Mycobacterium tuberculosis. Fits the name. TB is typically how people shorthand it. TB, tuberculosis. This is basically transmitted by, again, that oral droplet route from person to person, and the person has to have an active infection of TB. So yeah, so the person to cause an infection, this is TB is predominantly known as the condition or infection of like disease. It's a disease of poverty and overcrowding, basically. It's easily spread person to person, so overcrowding makes it worse. The reason it's known as poverty is that it's typically in these places around the world that have poor living conditions, poor water sources, poor nutrition, poor health, poor living conditions, that sort of stuff. And so that's where it's known more in America, for sure. The homeless population is going to be higher incidence. And then, other countries, underdeveloped countries, are going to have a higher prevalence of this disease. 1 to 2% of some of the new cases. Is interesting to note that they have multiple drug resistance. We've found some, we synthesized drugs to fight this bacterium, fight this disease. And we have some strains of TB that have, bacteria can mutate and develop as well, like viruses. They're just way slower to do it. But because of all the antibiotic use in recent years, we've had some resistant strains of tuberculosis and other conditions pop up. And this is like, you've ever heard of MRSA? MRSA is methicillin resistant Staphylococcus aureus. MRSA is a resistant strain of that bacterium, Staphylococcus aureus. And so these conditions have developed over time with our use of antibiotics and maybe even overuse as well. So pathophysiology, it's caused by the M. tuberculosis Mycobacterium. tuberculosis. It's resistant. It's a very strong. It has a very strong cell membrane. It's very resistant to certain disinfectants and can survive in sputum for weeks, even. So it's a long life. Um, it's destroyed by UV light, alcohol, those kind of things. Um, neutrophil. The problem with TB is that because it's such strong cell walls, they limit our neutrophils response and ability to swallow. Neutrophils are phagocytes. They want to go and swallow bacterium and destroy it, but they're very resistant to the phagocytic nature of neutrophils. And neutrophils are our most abundant first responder white blood cells. They are the guys that come in and get the job done. So they can't get the job done versus this bacteria. It makes it very hard for our immune system to fight off TB. And because it basically nulls our neutrophils, which are the most abundant white blood cell we have, the only really protection we have is our specific immunity with T cells and B cells trying to make antibodies. And it only primarily infects the lungs. It can affect other organs, but it only primary responses in the lungs. And so basically they break down TB into a primary infection and a secondary infection. So what primary infection is, initiates the response from our immune system. So cellular mediated immune system is really the one, because our neutrophils and non-specific immunity has trouble fighting this one. So it kicks into our specific immune response. And because it does that, it causes a lot of clusters of dead cells because the phagocytes just can't get the job done. So a lot of dead white blood cells and inflammation in local areas where the bacterium is found in the lungs, and it will cause what they call like a granuloma, like this big swollen inflamed spot. They know this is known as a tubercle. It's spelled tuber, CLE, so tubercle, like tuberculo. Tubercle basically develops in the alveoli, and it basically can collapse in alveoli, or the whole alveoli will undergo necrosis because of TB. So think of TB as developing these big tubercles that swallow up an alveoli and cause tissue necrosis or calcifying of the alveoli. And it'll look patchy on an X-ray, and so they kind of calcify and necrosis the alveoli, and then therefore limit functionality, limit oxygen transmission. This is the primary infection. Basically, when we first get exposed to organism, most risk for death and symptomatic. Secondary infection or reinfection with TB occurs when the client's cell-mediated immune system is impaired. So TB is one of those things, because of those tuberculums, can lay dormant. Basically, TB can lay dormant. It can cause an active infection. It can be treated, and then you never get rid of it. The bacterium is housed there. It still grows and develops. It just doesn't cause a systematic infection and response. That's known as latent TB, and it can last years. It's pretty much a lifetime. So once you have the initial TB infection, it's pretty guaranteed that you're never really going to get rid of it. It's possible, but very unlikely that you're ever going to fully get rid of the TB. And again, active TB is very infectious and spreads. But so secondary is known as like a reinfection. Basically, latent TB pops up because I have immune system compromised from just stress, bad nutrition, HIV, AIDS development, older adults. And active TB it's spread very easy. Some of the active stage stuff, you're going to have the normal kind of sickness symptoms, malaise, fatigue, anorexia, weight loss. So low grade fever. So I think some of the highlights for thinking about, again, differences, right, guys? Differences. What's different with TB? It has a latent stage, a dormant stage. It forms tuberculum and hangs out in the lungs. That's different, right? That's unique to TB. Very infectious through droplet. That's just no very infectious. That's TB. These are all fairly fatigue symptoms. So what's interesting? The night sweats thing, that's unique. So a very prolonged cough. And then typically sputum, or the stuff we cough up, contains blood. This is hemoptysis. Hemoptosis. I had to think about it. This means bloody sputum, basically. So there's your unique stuff with TB, right? It has a latent stage, very infectious, causes low grade fever and night sweats, prolonged cough, and often has very nasty, purulent sputum that often has blood to it. So hemoptysis. There's a Y. There's a Y in here, I think, for hemoptysis. I can't spell. We've established that Mr. Mossa cannot spell, but you get the gist. Again, so TB, when it's active and it's not in a latent state, multiple areas of necrosis, multiple tuberculum. Because it collapses the alveoli, typically it can promote spread to other parts of the cavity. The x-ray is going to show these tuberculum areas, these like calcified necrosis alveoli. So highly infectious, personal contact. And this is why it's kind of the disease of poverty and overcrowding, because people that live in poverty are definitely in places where there's lots of crowds, community, because of their dependence on other people or whatever for assistance, and then just different parts of the world that have dense, centralized populations in China and Africa and other parts of Asia, that kind of stuff. Again, we're still on TB. TB is a big one. That's where they get that TB skin test that you guys may have had to do for part of the nursing program and getting ready for clinical stuff. Is that TB has a skin test, and all that skin test really tells us is that at some point you've been exposed to the tuberculin. You've been exposed to TB. And that may have been even in a healthcare setting, you could have been exposed to it. You may have never had an active infection, but it's always possible for you to have a latent infection. Active infection, a chest x-ray is going to tell us a lot. We can do a sputum culture. And then the treatment is long-term treatment with a combination of drugs. A lot of times it's going to be like almost a year of treatment. And again, we can sometimes fully get rid of it. Sometimes it goes latent or dormant, however you want to word that. Latent is the correct term, and you kind of never get rid of it. So it's a tough bug. It's a tough one. It's a tough one. So tuberculosis is primarily transmitted via what? How's it primarily transmitted? If you said number 3, you were correct. Airborne droplets, highly contagious. Think airborne droplets, highly contagious. Okay, moving on. Trying to get through it. Again, hang in there, guys. It's a long one. Obstructive lung diseases. So lung diseases that basically obstruct airflow and breathing. So those were kind of the highlight for infectious lung diseases. Now we're talking about obstructive ones. Examples: cystic fibrosis, lung cancer. Aspiration fits in there, and it'll likely cause a pneumonia, but aspiration is kind of technically obstructive. Sleep apnea, asthma. So what is cystic fibrosis? So cystic fibrosis, CF, is sometimes called. CF is an inherited genetic disorder on chromosome 7 specifically, but just think of it again. All these diseases, all this stuff for the lungs, know the differences. There's going to be similarities between all these, but what makes it unique? CF, what makes it unique? It is a genetic disorder. Okay. Primarily, the effects are seen in the lungs. In the lungs, it's excessive mucus production. Our lungs produce mucus, just like our upper airway, to protect themselves, to catch dust or debris, whatever, keep it out of the alveoli, and hopefully prevent infection. But mucus mucus, just like inflammation, has a good reason it exists. But if too much mucus, just like too much of any good thing, is too much inflammation is bad. So this increase in mucus obstructs airflow. And then it has some common organisms that are causing it. Pseudomonas, Staphylococcus aureus are very common. as far as infections, not what causes cystic fibrosis, it's common bacteria that will cause infections. So it's always potential. The more mucus I produce, the more likely I am to suffer a pneumonia infection. So infections are common with CF patients, but think of extreme amount of mucus. This is a chart that kind of talks about it from your book. Again, excessive producing of a lot of secretions. It has like an endocrine effect, or excuse me, an exocrine gland. So these are glands that secrete stuff into ducts. So mucus, sweat, some of our reproductive glands, digestive tract, those kind of stuff. So there's other conditions. This is a little bit overcomplicated. I wouldn't worry about this. I think you'd want to know that cystic fibrosis is an autosomal recessive disorder, so genetic link, and large amount of mucus production because of its effect on exocrine glands. That's how you'd summarize it, right? So what is signs and symptoms? A lot of times you're going to see CF in newborns. You're going to see it early. See it early. It doesn't typically develop late. You're going to see it early. So meconium ileus at birth. Meconium is like the first stool, and it's usually a combination of amniotic fluid and some milk. It's a weird first stool, what's in the GI tract at the first stool. But if their meconium builds up, and ileus basically means a lack of movement of bowel. If the meconium builds up, then it's not going anywhere, and that's a problem. Salty skin is an interesting one. Malabsorption syndromes, chronic or frequent respiratory infections because of the excess mucus. And then they're going to have a limited growth and development sometimes for these children because of the disease process that's going on. So again, summarize this as, again, how would I say this? Mostly newborn infants kind of range of children developing cystic fibrosis. Not always. Other people can have it, but you see it then. And you're going to see failure to grow, malabsorption issues, that sort of stuff. Genetic testing, we can diagnose this. They can actually test stool. And then, of course, lung exams. So we have to do a well-balanced diet for them. And there's actually chest physiotherapy. What chest physiotherapy is a treatment, is basically promoting like proper coughing techniques, postural drainage, doing ways to drain the mucus, and then try to treat the underlying CF is what you're going to do for this patient. Aspiration, again, what I talked about earlier, I mentioned this before. This is the word aspiration just means any passage of food, fluid, vomit, any foreign material, anything that goes into the trachea and into the lungs that shouldn't be there. That's aspiration. This happens in young children, depending on like vomiting, that sort of stuff, or like I'm talking about like newborns, like laying flat in their bed and vomit and swallow it. That is all aspiration. Laying down when eating or drinking, and then common in the older adults. The older adults is the complication, where is the silent aspiration. So coughing or choking with breathing trouble. A lot of times you see aspiration with the dysphagia with the older adults with trouble swallowing. You're going to see that a lot with while they're eating. So if someone is an older adult and they're coughing a lot while they're eating, that they're probably aspirating, because the cough is our normal reflex to clear stuff out of the airway. So they could have some wheezing, hoarseness involved with that. And then some hypoxics, like increased respiratory distress symptoms if it was really severe, and even cardiac arrest and stuff like that, because their lungs get full. Sleep apnea, obstructive sleep apnea, is just basically the pharyngeal, the tissue of the pharynx, right where the mouth meets, it kind of collapses down when we sleep, closes off our airway, and stops breathing. Men are commonly more affected. And then genetic history is linked to this, your age, your size. This is where people need a CPAP machine, that blow by machine. It blows air through and kind of keeps the pharyngeal open during sleep. Someone that snores a lot is probably a sufferer of sleep apnea. Like me, I have a CPAP. And there's other appliances too besides CPAPs that can kind of like mouth guards that prop open the tissue and allow people to sleep. So there's other options. Asthma is definitely a need to know. What asthma is bronchial obstruction, basically. So the bronchi, the branches of the tree get obstructed. This is common hypersensitivity reaction, typically a um, hypersensitivity one interaction. Maybe more, it's more linked in childhood, but definitely can develop and happens in adults. But typically, you see asthma more in people that have a tendency of allergies or other conditions like that. Not always. And some people suffer from childhood asthma that they eventually grow out of. It kind of depends. I actually had that too. I had a childhood asthma, exercise induced asthma, and I played football, so that was fun. And then I got rid of it for several years. I got rid of it as I got older into high school and I grew more. So it's a lot of children that are small as they grow, their lungs get bigger and they grow out of asthma a little bit. But I was an idiot, went and smoked for like the last 15 years after I was in high school. So that kind of killed me, and now I have asthma again. So did it to myself. But yeah, so that's kind of asthma works. Extrinsically, again, asthmatic reactions can be just from outside resources of a hypersensitivity reaction to an allergen, and that's the type 1 kind of anaphylaxis. Intrinsic asthma is the more common. It's usually onset during possibly childhood. But we can get asthma, or excuse me, intrinsic is more, sorry, let me rephrase. Let me reverse. Sorry, I'm mixing stuff up. It's late on a weekend here. It's been a long weekend. So extrinsic asthma is more along with allergies, childhood asthma, hypersensitivity. Intrinsic is adulthood, maybe triggered by some kind of response like respiratory infections, exercise, irritants, certain drugs can trigger it, and then an adult would have asthma. It just kind of depends. Essentially the problem, the pathophysiology with asthma is that the bronchi and bronchioles, so the small, all the trees of the branches of the tree trunk and the lungs, the air, the move, the passageways that air moves through to get to the alveoli in the lungs get super inflamed, mucus production increases, and also there's bronchoconstriction. Bronchoconstriction is just like vasoconstriction. The bronchi all have smooth muscles that can kind of expand and contract, helping to move airflow more or less. And this inflammation response also increases the constriction of the bronchiole, which makes the airway tighter. And then there's mucus, and it makes the whole thing tighter. And this is why the airways get so tight. This produces that wheezing sound. So when you hear asthma, as far as breath sounds go, you're thinking wheezes, which is just this harsh, coarse sound that's typically on expiration. You hear it more, but it's an obstruction really of the airway. So they're going to have a tight chest. They're going to have wheezing. So again, uniqueness. What we're talking about respiratory conditions. How do we make them unique? Is someone that has cystic fibrosis going to have wheezing? Possibly, but you must see it more with asthma. So let's say asthma, wheezing, right? Put those two in together. Rapid breathing and wheezing with a sore chest. That's kind of like a tight chest. They could have tachycardia and hypoxia. It just depends. They could suffer from respiratory acidosis or alkalosis, because if someone's having trouble with a tight chest and can't move air, they're going to breathe harder, and they can actually cause a blow off a lot of CO2, but they can also have air trapping on the back end. They could have hypoxia and full like respiratory distress to respiratory failure, especially if the allergic reaction is very severe. It kind of depends. So on to our chronic lung diseases. These are the COPD, chronic obstructive pulmonary disease. These are the classics. These are the kind of most talked about chronic lung diseases. Really just these two for the most part. Bronchiectasis, we'll talk about, but emphysema and chronic bronchitis. Those are your main two culprits in the COPD family. So it's a group of chronic lung diseases that are all going to cause irreversible damage to the lungs, and they're debilitating. They're going to affect the ability of the individual to work and function on a daily basis. Going to affect their ability of ADLs, activities of daily living, getting up, walking around the house, cooking dinner, showering themselves, going toileting. It's going to affect everything. Can lead to cor pulmonale. Cor pulmonale is an enlargement of the right side of the heart, basically kind of similar to right heart side of heart failure, and they can have just general respiratory failure from this. So this is kind of the classification. I wouldn't say necessarily this is a need to know. I think this chart gives you some good information to talk about it, but I've got a few more slides that should help too. Asthma is technically included as a chronic lung disease, but nobody really diagnoses it that way. Asthma has its own diagnosis code. When I mentioned that, I'm talking about like the way insurance bills stuff. So I've dealt with some billing and coding before. It's called ICD-10. ICD-10, it says there's a code for everything. There's a code for that. A little inside joke with some of the people I used to work with, but basically it's saying that certain diseases are going to be coded a specific way. And so like COPD is going to be coded differently than asthma would be coded differently on its own. So it technically is a chronic obstructive lung disease, but it's usually separate because it has much more unique allergic childhood factors than the COPDs. The COPDs are always going to be not always, but typically developed in older adults that have been exposed to things like smoking, air pollution, like people that work in coal mines, that sort of stuff. And so this kind of gives you a breakdown of what the primary location and what's happening in these conditions. But we've got more slides that would, I think, will help too. So again, let's talk about emphysema separately. So this is under the umbrella of COPD. One type is emphysema. The alveoli walls get destroyed, or they get, a lot of times with emphysema, the alveoli, they're basically these multiple balloons is what an alveoli is, these round balloons, and air comes in, they expand a little bit, air goes out, they contract a little bit, but they never lose, again, their surface area. They never lose their, so they may either collapse in emphysema or they get air stuck and you can't get air gets trapped, air trapping. That's the, basically we want to, the differences between all this. When you think emphysema, you think air trapping. What happens? Cigarette smoking is a common cause of emphysema. There's genetic links. Infection can be a cause of it. So again, this is kind of showing you a normal alveoli, right? Kind of this sac. And then here is an emphysemic alveoli. It's kind of lost its separation in the capillaries. It's lost its structure. Its elastic fibers don't have good recoil, and it just is like a big balloon now. Air is getting trapped here. So they have the difference with emphysema is they have the air trapping. So they have progressively a hard time. Their lungs are overinflated. They have a really struggle with getting air out. So remember what I said at the very beginning of this lecture, if you can. I know it was a while ago, but inspiration, expiration, breathing out should be a passive process. It shouldn't require a lot of energy. It's about muscles relaxing and changes in pressure. So air movement out of the lungs should be a passive process. But in emphysema, air trapping, they have to work harder and kind of force their air out of their lungs. That's the difference. And so you get this expansion of the ribs and the cartilage around the ribs and the chest, and their diameter, their actual width and their diameter of their chest gets bigger because they're always trying to work hard to exhale. And so that's what you get, that they call a barrel chestedness with emphysema. And you'll see this kind of on so that's the need to know unique symptom with emphysema is the barrel chest, overinflation, air trapping in the alveoli. Okay. And signs and symptoms for both emphysema and chronic bronchitis are somewhat similar, but there are some differences. So they're going to have obviously dyspnea, specifically more on exertion, right? More on exertion. Barrel chest, they're actually going to have weight loss because of the fatigue. They're taking so much energy, right, to breathe out on a daily basis. Think about how many times you breathe a day. That's a lot, right? So they're taking so much energy. They're going to have fatigue and weight loss, and they're going to have that clubbing of the fingers. How we the PFT test, X-rays. That's how the people get diagnosis. Okay, so on the other end of the spectrum, we have chronic bronchitis. So chronic bronchitis is inflammation, obstruction, repeat infection could cause this. It could be from smoking or inheriting industrial chemical smoke, debris, coal mine is what I always think of. But they have inflamed and swollen mucosa. So they have inflamed and swollen bronchioles and alveoli. Um, so they have severe dyspnea and fatigue. And they usually have, with these guys, they usually have the cor pulmonae and the pulmonary hypertension. So, um, they usually have thicker mucus, pulmonary hypertension. So what is pulmonary hypertension? Pulmonary hypertension is saying that because all that mucus, they can't do the normal gas exchange because right, it's the alveoli is the blow up balloons, but they all have their own capillaries around them. Well, that capillary is microscopic, and um so again, chronic bronchitis, kind of your differences are they're going to have thickening of the bronchial walls, they're going to have increased mucus production, um they're going to be fatigued, they're going to have probably what they're going to suffer from is like fluid and mucus buildup in the lungs. And so they get pulmonary hypertension more commonly. They get high blood pressure in those pulmonary arteries. So around the arteries around the alveoli. So the alveoli changes aren't too much. They don't have the blowing up the alveoli like you see in emphysema. They have just a lot of mucus production and resistance of blood flow around the alveoli, and that causes the pulmonary hypertension, which can like lead to the right side heart failure because the right side of the heart, the cor pulmonae is what they call it, is the right side of the heart's trying to pump the blood to the lungs to get oxygenated, and it's meeting a lot of resistance. So they call these guys blue bloaters and the emphysema red puffers. And I'll kind of show you that image to kind of give you an idea. So again, really productive cough, a lot of mucus, shortness of breath, thick secretions. They're going to definitely be more cyanosis, hypercapnia, hypoxic, all due to the airway obstructions, vascular damage, and the pulmonary hypertension. So this is kind of like a comparison to show you, and that's why they colored these color. Emphysema, they color pink, and chronic bronchitis, they color blue. They kind of say like emphysema is pink puffers, chronic bronchitis is blue bloaters. And this really has to do with that the alveoli are actually damaged and filled with air. So emphysema, think entrapped air. So emphysema, right? Entrapped air. They're going to have weight loss. These people are usually really thin because of the anorexia and the energy they burn breathing. They burn so much energy breathing. So they have the barrel chest because of air trapping, and it's extreme shortness of breath and dyspnea, pink puffers. Blue bloaters for chronic bronchitis. They have lots of cough, lots of sputum production. So bronchitis, think boogers because lots of mucus. Peripheral edema because of fluid shifting, obese. They're going to be more blue, and hypoxia is more their trouble. And chronic, really terrible bronchi, just bad breath sounds. That's bronchitis. Hopefully that kind of helps summarize it a little bit better. So what distinguishes emphysema from chronic bronchitis? How do you answer that question? You need to know the difference between these two COPDs, the chronic bronchitis and emphysema. It's just going to be so much more helpful if you kind of get that down. All right. If you answer number one, you're correct. Think emphysema, alveolar destruction, barrel chest, chronic bronchitis. Think increased mucus, cyanosis, weight gain, edema, emphysema, weight loss from all the energy it takes to breathe out. So vascular disorders associated with the lungs. These are this is at the tail end. We talked about pulmonary hypertension, a little bit about pulmonary edema. So pulmonary edema is fluid collecting in the alveoli and interstitial area. So this is fluid that builds up, something like in the case of your blue bloaters, your chronic bronchitis, you're going to have that fluid collecting in areas and edema shifts. And this is going to reduce the gas exchange. Um, so this is severe inflammation. You could see pulmonary edema, like they call it sometimes flash pulmonary edema. You can actually see this flash acutely happen. You can see this in even like hypersensitive like asthma attack kind of a situation. Potentially you'll see this even in pneumonia. They can get it, especially if someone has pneumonia and they already have heart failure. One side of their heart's not pumping efficiently and there's already fluid issues for them. You could see flash pulmonary edema. And this basically the gas exchanges is the gas exchange is definitely bad. So they can have all the respiratory symptoms with poor gas exchange, but also they get this drop in osmotic pressure in the plasma, and that causes fluid shifts. And then fluid builds up. They can also have the pulmonary hypertension, that sort of stuff. And so this is just kind of showing you the steps. Like if I lose hydrostatic pressure or osmotic pressure, fluid shifts into the alveoli. That fluid disrupts the surfactant. The alveoli can't stay open; they collapse, and then I'm going to have hypoxemia, which is going to symptomatically show hypoxia, that sort of stuff. So again, pulmonary edema is going to be definitely more of the blue bloaters you're going to see as far as chronic lung disease. But breathing either way, breathing is going to be difficult with this. So mild pulmonary edema, the orthopnea is going to be a big symptom. And then they're going to have a cough. They're going to have that rales, that very like crackly, like wet lung sounds. Sputum, they're going to have, you may see hemoptysis. There's that why, but probably going to see frothy sputum. So pulmonary edema, you think buildup of fluid, you think frothy, like kind of aerated, bubbly, almost like a bubble bath, but not really, but bubbly, aerated sputum. And then just difficulty breathing and cyanosis. So pulmonary edema is often characterized by which symptoms? So this is one of those questions where there's possibly two correct answers. But what is it? You got to go to the root of what this question is asking. The question is asking you specifically pulmonary edema. What is a characteristic that's specific, right? Unique somewhat to pulmonary edema. And it technically would be number 4 because they can have hemoptysis. That would be the pink red tinge. And then the frothy sputum thing. Could they have dyspnea? Definitely. But what is that unique to pulmonary edema? No, that's pretty much, this is consistent symptom with every lung issue. So this is kind of how the nursing world does this. And so here at the end, we're talking about pulmonary embolus. So a thing to know about blood clots, and I kind of mentioned this before, but just to keep this in mind, if I haven't mentioned this before, is that if a blood clot if a blood clot forms somewhere in a vein or an artery and stays there, it's called a thrombus. But as soon as that blood clot were to break away and move from its original location, it's now known as an embolus. It's a moving blood clot. So blood clots form usually in deep veins, big veins in this inferior section of the body that are dependent. And if they break apart and move, it's now become an embolus. And that if that embolus makes it all the way through the heart, out of the right side of the heart to the lungs, think about the alveoli. They're microscopic. So those capillaries around the alveoli are tiny, tiny, tiny. And we get a clot, it wedges in there. That's bad deal. So Sometimes that's called a pulmonary embolus, and a PE is usually a shorthand, PE for pulmonary embolus. This can be deadly. Deadly. This could kill someone quick without very little symptoms. Depending on how much of a lung it blocks, it goes straight to respiratory symptoms and chest pain to drop dead. It can cause sudden death, and it's a catastrophic. It can also have multiple P's that are small and lung function still remains, and they can treat it, and people will live. So it just depends. But they typically relate from deep veins in the legs. So again, chest pain that's all of a sudden, cough and dyspnea. They could have tachycardia, restlessness, anxiety, those kind of things. Prevention is going to be about teaching. We're always going to be more at risk after a surgical procedure of blood clots. And that's why they usually do something after like procedures like TED hose, anti-embolic stockings, anticoagulant drugs for like big surgeries like orthopedic surgeries. They do things like Lovenox and heparin to slow down the clotting of blood to prevent clots from forming, because after any surgical procedure, your mobility and your functionality may be reduced. And that's normally how we move blood flow effectively from our dependent limbs, like our legs. With gravity, we have to be moving. If we're moving, we keep blood flowing effectively. And then diagnosis, there's a lung scan, MRI. We can check it out and see like where the clot is and how we can treat it, that sort of stuff. Again, if it wedges somewhere in the bronchial, we can probably have symptoms and we can treat it and fix it. But if it gets wedged down into the small bronchi around the alveoli, it can cause massive amounts of area of collapse. It's just a scary one for sure. So again, we're getting towards the end. We're on the last tick here, but it's a long one. So these are talking about expansion disorders. So basically what that means is limiting the lungs' ability to expand. So the lungs can't expand, then they can't breathe effectively. So you have atelectasis or atelectasis. That's how I say it. Atelectasis, atelectasis. You can say it however you freaking want, right, guys? I mean, it doesn't really matter. Atelectasis is basically a collapse of the lung or part of the lung. Is what will happen. Basically, atelectasis is a post-op complication where the alveoli lose the air and collapse. And this can happen in pneumonia. This can happen in post-lung. It can happen kind of anywhere. But what we do to prevent this is just promoting deep breathing techniques. And that we use that with the incentive spirometry. We're telling people, hey, again, airflow is obstructed. There could be a mass causing it, but we basically want to just make sure that we promote healthy breathing after surgery, and that usually prevents this healthy deep breathing. That's what the incentive spirometer is for. Have you ever seen those in hospitals? To make people take good deep breaths, because combination of maybe pain meds and the surgical procedure, you're not moving around as much. You're not going to take good deep breaths. You have very shallow, weak breaths. A pleural effusion is excess fluid in the pleural cavity. So pleural cavity is the double layer membrane that surrounds you for lungs, attaches it to the thoracic wall, and then attaches to the lung tissue themselves and helps with expansion and the contraction of the lungs. And there's fluid in that double layer in a small amount. If fluid increases, that's called a pleural effusion with an E. Increased pressure in the pleural cavity. It can cause lung collapse, which we'll talk about in a second. It can be full of exudate, like from infection. That's bad news. Could be because of changes in our osmotic hydrostatic pressure. So edema and fluid shifts. Heart failure patients, you'd see this. They're going to have chest pain and dyspnea. If their lung collapses, you see this. We're talking about a lung collapse. Tracheal deviation. What is that talking about? So if you look at your neck right now, like in a mirror or something, your trachea, you can kind of see the outline. It should go down right midline, right of your neck, of course. If your trachea was all of a sudden deviating to one side or the other, that would tell us that the lung is collapsed, and that is bad. That's an emergency situation that needs corrected ASAP. So pneumothorax. What's a pneumothorax? Pneumothorax is just the word we use to basically uh, say collapsed lung officially, right? So if you want to say collapsed lung in medical terms, you call it a pneumothorax. So typically this happens when air gets into the pleural cavity, that cavity in between the two layers. That's going to be a pneumothorax. So there's different types: closed, open, and tension. More focus on, so like closed would be spontaneous or idiopathic, meaning without really a reason. Sometimes you see this in young males that are thinner males that also smoke. It seems to happen. Atelectasis can cause this. Puncture would be like a wound, like stab wound or a puncture wound from like a motor vehicle accident, puncturing through the chest, because you got to remember that the chest is a negative pressure system, meaning that the pressure is lower in the lungs. And so if I make a hole into the lungs or the pleural space around the chest from the chest cavity, like in a stab wound or puncture, then air will rush in and air will collapse the pleural cavity, then collapse the lung, causing pneumothorax. And there's these people with all of these people with a pneumothorax going to need a chest tube to help kind of correct the negative pressure issue and get the lung back inflated, basically. And then tension can be open or closed, but it's usually like a tear, or tension is usually going to be more related with other medical conditions. So just know what a pneumothorax is. Actually ignore this question for now. I'm not going to do this question. Almost at the end, guys. Hang in there. The adult respiratory distress syndrome, ARDS, 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 adult respiratory distress, is just basically a full systematic failure of the lungs, basically multiple alveolar wall collapses. This is often associated with multi-organ system failure, dyspnea, restlessness, shallow, really weird breath patterns, increased heart rate. Could be metabolic acidosis, respiratory acidosis involved. This kind of gives a nice breakdown of it. I think it's probably too detailed for you guys at this point, but it is interesting what ARDS is. And then acute respiratory failure is very similar to ARDS, but has different results. Usually you see ARDS in people that have organs failing, and it's kind of this whole thing. Acute respiratory failure can be caused by a more specific disease process. So you got your emphysema, bronchitis, because your chronic conditions. It can be acute from severe pneumonia, those kind of things. Most of the signs and symptoms of acute respiratory failure are going to be related to correcting the primary problem. So when you think about respiratory failure, it's more of a secondary response, where ARDS is like a secondary response to organ failure. Acute respiratory failure is a secondary response to primary conditions, disease processes. Okay, so that's where I'm going to end it. That wraps up Chapter 13, the respiratory disorders, one of the longest and toughest chapters we've talked about so far in Patho. So let me know what questions you are. Please try and review this ahead of time. I know it's challenging as I'm getting these out.